Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day. We want you, yes, you, to join the Behind the Knife team as a surgical education fellow. We're looking for enterprising surgical residents to take the bull by the horns and build something new and exciting. Fellows will benefit from ample support from the Behind the Knife team, including the use of our digital education platform and access to all of our resources like illustrators, video editing, AI tools, social media, and more. Get your name out there and build your CV by being part of the #1 surgery education platform in the world. We're offering a 2-year fellowship starting in July 2026 and ending in June 2028. Only residents beginning their 2-year academic development time will be considered. Check out the show notes for more information, including the application link. All applications are due on April 20th. Again, all applications are due by April 20th. Now, get out there and dominate the day.
Hey BTK listeners, want to feel more confident in the OR? Check out our surgical instrument flashcards. With over 300 instruments, these cards are packed with key tips, subtle distinctions, and insider tricks you usually pick up after years in the OR. Perfect for students, surgical technologists, or anyone prepping to scrub a case. You can find them in your library on the Behind the Knife app or at behindtheknife.org. Test your knowledge, share them with your learners, and as always, dominate the day.
Hey everyone, welcome back to Behind the Knife. This is Cody, Patrick, Jason, and Ayman, and today we're going to be talking to you about something that every surgical trainee will experience and remember for the rest of their career, which is presenting at Morbidity and Mortality Conference. No matter where you train, M&M is one of those experiences where you can feel your heart rate creep just a little higher when you walk in to present. Your name's on the slide, cases queued up, and you know the discussion is going to be thoughtful, detailed, and led by people who have seen everything.
Yeah, and if you're a resident listening to this, you've probably remember your first M&M presentation, or you can picture it, or maybe you have nightmares about it. It's definitely a formative experience. So it's not just another case conference. It's one of the places where surgical identity gets shaped. It's how we talk about complications, how we learn from them, and how we treat each other throughout that process.
And it's formative because M&M is one of the defining professional rituals of surgery that's pretty unique to surgery. It's where we model accountability. It's where we publicly examine decisions under real uncertainty. And it's where we demonstrate in a very explicit way how surgeons think.
Our goal for today is simple. We want to give residents a roadmap for preparing high-quality M&M presentations that actually facilitate learning for other trainees in the room and that communicate very clearly to an experienced audience. We want to do it in a way that's practical, what to include, what to leave out, how to frame the case, and how to prepare yourself.
We also intend for this episode to be useful for attendings, who will assist a resident in preparing for the presentation, add to the discussion, and maybe even moderate the session.
It's also important to clarify what we won't be diving into today. So this is the profound emotional weight of having a complication laid bare at M&M. This is arguably one of the most harrowing experiences we face in our profession. It's a weight felt by residents and attendings alike. When a mistake happens and a patient suffers, the resulting guilt and self-doubt can be absolutely overwhelming. Often, just as you're starting to emerge from that initial kind of post-complication fog, that M&M notification hits your inbox, you see it, your heart sinks. Standing before your peers to dissect a complication is a uniquely miserable hurdle. So because these emotions deserve their own dedicated space, we're going to let Steve Thornton, one of our exceptional BTK fellows, look into this farther. He's curating a special series exploring the role of shame, specifically in surgery. So it's obviously a vital conversation, and we're looking forward to that. So we are not going to be covering that part of M&M today.
Well said, Patrick. One quick note before we move on. The best M&M presentations often feel deceptively simple. And that's because the presenter did the hard work up front, deciding what matters, choosing what to omit, and building a narrative that the room can actually hold in working memory.
If you're listening to this and saying, man, I'm a busy resident, I don't have time for that level of prep. Well, the reality of the situation is you don't have time not to. M&M is one of the few places where the whole department is focused on the same case, and your preparation determines whether that attention turns into meaningful learning. Also, in a real sense, the way you present a complication shapes your own relationship to it. When you can describe the facts clearly and analyze them without shame, you build the kind of professional resilience that you're going to need for a long career in surgery.
One thing up front is that it's important to ask for help early and in some places expected. Ask a senior resident who you look up to sanity check your timeline. Ask the chief to look at your slides. Ask a fellow or attending what questions a room tends to ask. And you may even consider asking the moderator who selected the case if they had any particular interests or learning points in the case they want you to incorporate. Just like everything in surgery, prep for M&M is a team sport.
Yeah, Ayman and Cody, you guys, who do you like to ask in advance when it comes to reviewing your presentations?
Yeah, personally, I always will reach out to the moderator first and get a sense of what kind of questions they want to ask. As a junior resident who may have presented more cases than I should have, I think that was one of the most valuable things I could do. The other thing I would do after that is just immediately reach out to the attending who I did the case with. And once you have that as a foundation, you can ask other residents to kind of help tweak things. But I think getting those two is not just something you can do, it's something you should do.
I totally agree with Ayman. I think, the moderator probably selected the case for a particular reason. So trying to figure out the rationale for the selection and kind of what, from their standpoint, some of the key learning points may be related to the case so that you can incorporate that into your presentation. And then one other pearl, just to build on what Ayman said, if you rotated off service and maybe you weren't necessarily involved in the patient's care when the complication itself actually developed, it's always good to talk to the chief resident who might be running that service after you to get a good sense clinically of what might have happened in the patient's rescue and their complication.
Yeah. So Cody and Ivan, do you guys want to know a little secret that Jason and I keep from you? We also ask colleagues and other specialists about the case in advance, or at least I do. Jason, you talk to anyone else?
Oh yeah, absolutely. I mean, that's the best part about having good partners is you can, go to them and, kind of lay it all out there and process it. So I talk about all my complications with my, trusted partners.
Exactly. It's good for processing mentally, clarity. And there's always something that comes up. I'm shocked because with a lot of these cases, you feel awful. Something bad happened to a human being. And so you feel terrible and you look at it and you think about it in the way you don't think about any other cases. And just when I think I have it all figured out, every angle figured out, my partner will be like, hey, like, what about this? Or just think about this. I'm like, oh man, what a great, suggestion. And I think that's also just extraordinarily valuable for our conversation right now, which is how do we present at M&M? Well, Jason and I, as staff, like to say something about our cases too, right? And so we want to have our thoughts in line. And so getting everyone's feedback is so important. And, historically, most M&M conferences may have had a more punitive tone. It's kind of like the knee-jerk reflex. You hear M&M and it's like, oh man, this stinks. And that certainly can create a culture where people become guarded. It's my impression that the majority of institutions, but maybe not all, have largely moved away from some of that heated rhetoric and that kind of that blame-centric focus, that dominated these surgical auditoriums in mornings past. And that's a good thing for sure. So modern M&M, when well done, is something that's systems-focused, it's educational, it's reflective, and it's structured in a way that we can learn from the inherent complexity of what we do as surgeons. And in my opinion, when it is well done, this is the single best learning opportunity that we have as surgeons.
And that shift you're describing, Patrick, matters because the resident presenting the case is not there to be on trial. Your job is not to defend yourself. Your job is simply to tell the story clearly. What happened, when it happened, what the team knew at the time, what decisions were made along the way, and some reflection of what could or should have been done differently that may have changed the outcome for the patient. Then the room derives meaning from it. The room identifies learning points. The room identifies systems issues and cognitive traps and potential technical considerations. And ideally, the room does that in a way that makes everyone in the room better, including the next resident who's about to face the same decision in the operating room later that day.
I'd actually take it one step further. So for me, M&M is about making sense out of uncertainty. This job is full of imperfect information. Patients present late. Physiology evolves. The imaging's not always definitive. Consultants disagree. And, that right decision is often only obvious in hindsight. Yeah. So M&M is where we can slow the case down and ask, what did we think was happening? What were we worried about? What signals did we prioritize? What signals did we ignore? And how do we navigate the trade-offs that were in front of us at the time? And what, if anything, could we or should we have done differently?
Yeah.
Yeah, I think it's important that the resident really focuses on telling this story and knows that the burden of interpretation and education is not entirely on them. So it's the facilitators and attendings in the room that really have a responsibility to do the analysis, to model the professionalism and humility associated with the case. And if the discussion becomes a gotcha, everyone loses. If it becomes defensive, it really loses its educational value.
Yeah, that modeling humility is such a huge thing. And M&M is not about blame. It's not about shaming. And it's not about the presenter trying to prove that they did nothing wrong. That's not a very good way to approach it. And it's also not about pretending that nothing could have been done differently. Again, as Jason said, you want to try to find, what are those pieces of that puzzle as you put it together that could have been different and would have led to a different outcome.
Yeah, it's about collective learning and it's about modeling accountability. One of my mentors early on told me very early in my training, run towards your complications. And that really stuck with me.
I like that.
So, when M&M's done well, it reinforces what makes surgery particularly unique. Not all specialties do this. We're unique in that we strive for transparency, self-critique, and continuous improvement.
It's a great point, Jason. So now that we understand the context and purpose of M&M and kind of how it's evolved, the next question becomes, which cases actually belong at M&M?
Yeah. Now before we want to jump into that, I think we should take just 1 second and think about how bonkers it is and that we do this at M&M, that stand up there in front of all of our colleagues and say, hey, this is what went wrong. I can't think of another profession that does this. I mean, it's a profound thing to do, to stand up there and own it and to learn from it. And again, that's why we're here today, to talk about the importance of it. But it's just, if you really think about it, it's something special.
And you think about I think about when I was in training, the staff surgeons and my mentors that are really respected, they weren't the guys that hid from their mistakes. They weren't the ones that had no complications. They were the ones that looked it straight in the face and owned it and learned from it.
It's very much a bonding experience. I mean, especially as a resident and especially as a junior resident, when you're presenting your first M&M, at least when I presented my first few, you get overwhelming support from everybody. And I think it makes you really feel like you're a surgery resident in a sort of odd way, but it really helps you deal with the complication and get closer to your peers in the process, because it's something everyone experiences. And I think something that, and Stephen may talk about this later, something that we may not know how to handle us without this.
Yeah, we're going to come back to that. It's cathartic in a lot of ways.
Yeah. So Patrick, how do you tell your residents, or how do you at your institution decide what's an appropriate M&M?
Yeah, I think this is really important, right? Because we kind of said, oh, hey, M&M's this, M&M's that. It can be great, and we've kind of, to some degree, it's like this positive, very positive way we framed it so far, and that is, if done well, right? If done well. And so I know there's places that maybe don't do it as well as they could, and that's something that can always be improved on, and every institution can improve and iterate. And I know a lot of places like Duke and Michigan and other places have gone over time, iterated and keep trying to improve on the process. And that comes back to, Jason, your question of appropriate cases. So these cases could be unexpected outcomes. They could be preventable harm, deviations from standard practice, or even near misses. And certainly all these cases have some clear educational value. And educational value doesn't necessarily mean that the patient had a catastrophic outcome. Sometimes the most important cases are the ones where you barely avoided them because they reveal the same underlying issues that other folks are bound to come across. And some institutions have even may even review big wins. So maybe a case that could have gone terribly wrong, but didn't.
Yeah, we instituted that. And I think that was into our M&M where we do a case that was a near miss or a big win. And I think it's a really interesting way of going about it. At kind of a higher level, I think residents should think about cases that, challenge assumptions. Cases that expose systems inefficiencies, cases that reveal cognitive biases, where, the team's mental model didn't really match what the patient's physiology was actually doing. Those are cases that really kind of move the whole group forward because they teach, pattern recognition and decision making and not just the technical details. And, I think, well said that, when we were kind of younger in our training, I dreaded M&M, because, it was scary. But now at this point in my career, I think it's probably my favorite conference that we have. And it's the one that I really learn the most from. You can see what other people do in difficult situations and get that pattern recognition. So when you're in that same situation, next time you have that kind of in your toolbox.
Yeah. From a logistical standpoint, each institution has their own way of flagging or listing or choosing cases. And many have developed formal systems, especially with an eye towards these, choosing cases equitably and to optimize education, because no one wants to feel targeted at their own institution. But regardless of how it's done, it is incumbent upon trainees and the staff to submit appropriate cases. So you never want to try to hide a case. This will only draw more attention to yourself. Like Jason said, you want to run towards your complications, not away from them.
And I want to normalize something. When your case gets selected, it's stressful, even for confident residents, even for senior residents, and even for attendants. That stress is normal because you care. Instead of viewing it as a punishment, it's helpful to try and view it as an opportunity to demonstrate professionalism, where professionalism here means that you did the work, you know the details, you present the story clearly, you're honest about uncertainty, and you're willing to learn publicly.
Yeah. Going back to what Jason said again, I like that so much. Run towards your complications. So if you're secretly hoping that your case doesn't get picked, that's probably the exact case that needs the most discussion. Not because you're in trouble or did something wrong, but because your comfort is a signal that there's something meaningful to learn for yourself. And then if you're looking at it meaningfully for yourself, that means others are going to learn from it too. So everyone on this podcast has learned an enormous amount, I'm sure, and even Ayman and Cody in your young careers from presenting and or discussing your own cases.
Yep. Yeah, totally agree. And as I was more of a junior resident, I was increasingly guilty of having my hand up and hoping that that case that got listed that I was a part of did not get chosen. But as I've kind of matured throughout my training, although I'm still, only a few years in, I totally welcome the opportunity to present cases that I've been a part of and always look forward to learning from others. Okay. So you have a case. Now what? Let's talk about how to tell the story and how to present a great case for M&M.
Yeah, it's the meat of this podcast, right? We want people to present well. Okay, so most institutions have a slide template. Not every institution actually uses PowerPoint. I think most do to some degree, some more sparingly than others. But regardless of a format, a strong M&M presentation shares the same structure. And really, you can think of it as a narrative with important anchors. And so you can start with the one-sentence headline. The true headline, it should tell the audience immediately what happened, why we're here to talk about it. For example, you might have a post-op day 2 hemorrhage after laparoscopic right colectomy requiring reoperation. Or delayed recognition of an anastomotic leak after sigmoid colectomy. So clearly those headlines set the expectations and it tells the room what they're listening for, what they need to key in on.
That's great, Patrick. And then from there, you build a clean and chronological narrative. And that chronology drives comprehension for the rest of the room that wasn't taking care of that patient or a part of that case. And the way residents get in trouble at M&M is not because the case was too complex. It's because the story was hard to follow for the audience. So anchor your narrative with timestamps and time intervals, day of admission, time of the operation, post-op day 1, time of first fever, time of first CT scan, time of reconsult, time of escalation, and so on and so on.
Yeah. Now, with that said, though, you definitely want to avoid irrelevant details. I think this is where especially junior residents stumble the most. It's so important. It's probably, in fact, the most important recommendation from this podcast in regards to structuring your presentation. It's certainly tempting to tell the entire hospital course like it's a discharge summary, but the audience doesn't need that. They don't need to hear every lab or every system abnormality. They need the facts that explain the decision points and, again, frame the educational narrative, an educational narrative that you're going to choose. So you want to keep it clean. You want to keep it tight. You want to create a truthful but deliberatively curated presentation.
Yeah, I would say you want to have a structure in your mind. So for me, non-negotiables are, the pertinent background. You have a clear timeline with key decision points, present objective data, the outcome, and what you would or would not have done differently the next time. If you can't identify the key decision points, The room can't analyze them. They're going to get lost, and they're really going to take nothing away. The key is that people are able to have this as a meaningful learning conference.
I remember the first time that I presented at M&M, our moderator was one of the more experienced moderators. And when I called him beforehand, he told me that I have 3 minutes to present my case and the rest of the time will be used for discussion. So his advice to me, and the practical pearl that I've used since, is that the more concise your presentation, the more valuable the discussion will be, because you give the entire room time and space to think. Personally, you should know the whole patient course. You should know the final pathology. You should know that detailed summary, and you should know the final culture results, what happened after discharge. But you don't have to present all of it up front. Present what's important, and if anything else is necessary, people will ask.
In terms of visuals, imaging is very powerful. Having that CT scan up there with those key images, if you have the ability to kind of scroll through the CT scan and, let people see what you were seeing at the time, that's very helpful. If you can't do that, at least have representative screenshots of key slices, and it really helps the audience understand what your thought process was and what you were seeing.
I'd say that a lot of institutions also will have the radiologist present too. And so ideally they can be keyed in advance to the key images, which dates and which specific pathology is looking for on those images to ensure that that presentation stays crisp. So preparing in advance with everyone, including the radiologist, is a good move.
One of my favorite things about a good old VA case that gets presented at M&M, though, is the manual video with the iPhone of the stroll through the CT scan and good old CPRS, although I hear that's going away relatively soon with Cerner. Let's run through the don'ts, because these are traps. So during M&M conference, don't editorialize, don't apologize, don't assign blame, don't bury key information, and lastly, don't over-speculate.
Yeah. So what you're talking about is this is an art form, right? I mean, this is really an art form, presenting a complex case, choosing the most important points to draw out educational value in a way that facilitates that discussion while maintaining, absolute truth and clarity it's tough. It's tough, but you see people do it well, and it's a beautiful thing. So, you want to include those cold hard facts. And I think from a stylistic standpoint, you want to have that healthy dose of introspection, right? As you're standing up there, and humility, kind of really speaking in a way and your body language in a way that shows those things. And you can earnestly, ideally, describe how you could have done better. And this comes with the idea of falling on the sword, right? And I would say that it is appropriate to fall on the sword, but you don't want to overdo it, right? So if you transected the common bile duct, you should fall on that sword, right? But if you had an anastomotic leak in a malnourished patient, with a prealbumin of 6 on chemotherapy, you don't need to make a scene impaling yourself up there, in that circumstance. So key differences and important style points.
Those are awesome points, Patrick. A few other style points. You don't need to walk through every operative step of the index case or the take back unless it's actually relevant for the case. When you're describing a case, you should be describing it as if you're describing an oral boards exam, using the key steps, key maneuvers that get you through that operation. And then from there, if the complication's technical, you'll need operative detail. For instance, if you're discussing that anastomotic leak, knowing how the anastomosis was formed, whether it be stapled or hand sewn, what the staple size or load or the type of suture were, those are essential details. But details about how the fascia was closed is not.
Yeah. Keep it simple. Keep it simple. Keep it.
Yeah, I think a practical, trick for doing that is narrate it like you're handing the case to someone who wasn't there. If a neutral listener can't answer what happened next, why did the team do that, then your narrative needs more structure, not necessarily more detail.
Yeah. So a simple checklist you could use is, can I state the complication in one sentence? Another good kind of check mark is, can I point to 2 or 3 moments, those anchors we talked about earlier, where the trajectory could have changed if a different decision was made? Those are extremely important. And if you have those pieces to the puzzle, you're going to be about 80-90% of the way there in terms of a good presentation.
And remember, when you're choosing what to put on the slides, you're not deciding what's true. You're deciding what's useful for learning and for the people that is in the room during the M&M presentation. The full chart is the full chart. Your slides are the teaching tool by which everyone in the room can learn.
Yeah, guess what? So every presentation that you see where someone puts on 900 words on a single slide and you're like, drift off and start looking at your phone, that's the same thing applies to M&M. So your slides should be well styled. We talked about a timeline, or you can choose whatever you like, but don't put 10 bullet points on the slide of heavy text. That'll cause everyone's eyes to glaze over too. It's just same for any presentation. And when it comes to the analysis, because you are probably going to include at least one slide on the analysis or at least a statement on that, it's probably good and certainly in your mind in advance to explicitly separate an individual decision versus some system conditions. Because we all work in complex systems, and a lot of these complications may not be directly the result of a surgeon making a certain decision. It may be a systems-based issue. And so being able to clearly state that helps frame that educational discussion and lead to more productive back and forth between the audience when the case is discussed about the system itself. Because guess what? Everyone who's in that room, they also work in the same system and oftentimes have the same frustrations.
Yeah, and you should not be worried that bringing up system issues sounds like making excuses. You can say, here's the decision we made, and these are the conditions we were working with. That framing is honest and mature, and at least at our institution, important, because the system issues you bring up go right back to the attendings, and often things change.
And don't underestimate the value of asking the room for their own mental models or thresholds for making different decisions. Patrick, what's your threshold for bringing up a lupostomy or doing an ED thoracotomy or shooting an IOC or whatever that thing is? You'll find that senior surgeons often have different thresholds for CT, ICU transfer, when to take a patient back, when not to, calling a friend, asking for help, placing a drain or not placing a drain. M&M is one of the best venues to kind of dissect those thresholds and hear how others do it, and you start calibrating your own thresholds for these various decisions. And again, keep it simple. If your slide looks like a discharge summary, it's way too dense. I can't agree with that more.
And the last point here is that your tone really makes a difference. Having a neutral, factual tone invites better discussion. If you sound too defensive, the room will get tense. And if you sound too vague, the room can't help, and it takes away from discussion. If you sound overly self-critical, the room ends up reassuring you instead of learning from the case. And like Dr. Georgoff said, you do not always need to fall on the sword.
So you've told the story. Now comes the part where the case turns into learning, which is the analysis.
So at most institutions, there's an assigned moderator for each M&M. Like we said before, talk to them beforehand. Their goal is not to surprise you. They usually have a set of teaching themes they want to emphasize, and if you align on those themes, the discussion is more focused and less stressful. Having that in your mind also helps you anticipate what the room may ask and where you might need a clearer slide or a clearer timeline.
So when presenting the contributing factors, use a structured approach. A simple framework to consider patient factors, disease factors, system factors like we talked about earlier, cognitive factors, and technical factors. Patient factors might be things like comorbidities, physiology, frailty, communication barriers. Disease factors might be severity, atypical presentation, rapid decompensation. System factors may be issues related to handoffs, to staffing, to access to timeliness of imaging, delays in consultation, or unclear ownership of a decision.
Yeah. I think the cognitive factors are huge because some of that stuff you just mentioned, Cody, is totally sensible, right? A patient's comorbidities, for example. But the cognitive factors are something we don't talk about quite as much in surgery. They play a huge role, though, in the decisions we make. A few like anchoring, which is when you stick with the first diagnosis, or premature closure when you're deciding that you figured it out and you stop reassessment of a patient, or even availability bias where you weigh more heavily than you should, something that you recently saw. All these different types of cognitive factors fit into that Swiss cheese type model. And if you pay attention over the years of M&M, and I'm sure, Jason, you can attest to this too, that there are cases where it's like a big oopsie, right? And an unfortunate one. But most of these align with that Swiss cheese model. A few things happen, or sometimes even more than a few, where the Swiss cheese model prevails and a rare or potentially devastating complication happens. And a lot of those, part of those pieces then often have a cognitive factor in it baked into these other patient factors, system factors, et cetera. But Jason, I don't know if you have any thoughts on that. I'm usually struck by kind of how it's rarely one thing.
No, definitely. And that's where that kind of pattern recognition comes in, because these are things that you're not going to find in a textbook, like these patient courses. The patients have complex physiology, and there's things that are outside of our control. What's available in your hospital, what you're on divert for, those things that are really outside of your control. So it's looking at that whole system and how that, certainly your actions, but also just the nature of the disease, the system you're working in, how all those things interplay to patient outcomes. And you'll start, the more you see different things play out differently, you're going to start to form that pattern recognition, and it really is going to help you be a better clinician and a better surgeon. So, along those lines, I think it's critical to avoid that hindsight bias, right? With the benefit of hindsight, you can always say what should have or should have not been done. But that's not the educational question for M&M. The question is, given what you knew at the time, what options were reasonable? What information didn't you have? What signals were there but you missed? And what would have made it easier for the team and the system to choose a different path and potentially have a different outcome?
Yeah, totally. And you need to present those alternatives objectively. If there are reasonable alternative strategies, whether it be a different imaging modality, a different threshold for considering a reoperation versus a drain placement, choosing a different set of antibiotics, or disposing the patient to a different level of care, lay them out clearly without judgment and let the audience kind of stimulate discussion around that. And when it's appropriate, incorporate a small amount of literature. Now, I'm not talking about a full-on journal club, just one or two key data points from high-level data and high-level studies that may inform best practices or show where practice variation is to be expected.
Yeah, you'll see too, if people have made their own personal journal club on the slides, that you never get to it, right? Especially if you have a strong moderator, because a strong moderator invites and encourages discussion, a robust discussion, engage the audience, etc. And you may be able to make reference to those and should make reference to the data, the literature itself. But again, this is not a journal club discussion.
Yeah, the role of that moderator is, if it hasn't come up already, is to ask that mature question. What would you have done differently? Sometimes that answer is nothing. That's fine. M&M is not guaranteed that every case is going to yield a different decision, but it's a guarantee that we examine that decision carefully. So that's how we almost end every M&M. The resident will present the case, and it's a very simple question. All right, well, what would you have done differently?
I remember doing a case as a trainee and getting into the senior years at some point, and I couldn't think of anything to do differently. Like, I had nothing. And that was the first time. Usually you can think of something, okay, right? You want to be very careful saying there's nothing I can do differently, because there's almost always something. Now, you don't want to wander off into the ridiculous part of it, but I remember asking, just like we talked about, I asked all these different people, just going to say, hey, I don't have anything I'd say differently. Is it okay? I was reassured, yes. And I stood up there, gave the presentation, went well. And then it was at the end, what would you do differently? I said, in this case, nothing. No one said anything. I was like, whew. Ran back to my seat.
Fair enough. And so that brings us to our final topic, though, which is how attendings can best support trainees and set the tone and set a great example for a strong, thoughtful, and informative and educational M&M.
Yeah. Attending set the tone, right? Expectations should be clear. We talked about the word humility before. That should be modeled. I've seen staff, and I really appreciate this, and I've done this a time or two too, and I think it totally lowers the temperature of the room, is if you've had a similar complication before, you can say so. And that single statement can turn that M&M discussion from something like a public judgment into something more benign. It's something like a shared experience, right? A shared professional learning experience because of that single statement.
Yeah, I've also seen attendings the resident's really up there kind of just taking it. And it's nice when the attending steps up and says, this, I did this. This was my decision. That I think is, I really respect that when that happens. And, that comes down to transparency. Transparency matters. You don't want to be the attending who's known for trying to hide your complications. We've all known those people, and it's not an admirable quality. So you don't want to be the person that tries to distance yourselves, like we talked about. Run towards your complications. So all that does when you behave that way is it erodes trust, and it creates a culture where residents feel like they have to protect people instead of telling the truth and learning.
Yeah, totally. And now attendings can listen up to this part because these are some tangible pearls from current trainees of things that faculty can do that make M&M more kind of easily presentable for their trainees, both from a practical standpoint and setting the tone and culture like we've already been talking about. And that's that residents benefit when cases are identified early so they have plenty of time to prepare their presentation, when expectations for the case are clear, when the attending of record is physically present for the discussion. Your presence matters.
Ding, ding,
Even if
ding.
you don't say much, being there signals that the resident is not alone in presenting the case and sharing the complication, and that this is a shared responsibility. Ayman, do you have any other thoughts as the other trainee on the call here?
Yeah, I mean, I think that as a trainee, the first question you get asked by the attending in the room really sets the tone for the rest of the discussion. And so that first question, if it's really an accusatory type or a sarcastic comment towards you, it's hard as a trainee to know how to respond. The room tightens up, and I think it makes the productive conversation less likely to happen. But if that first question is a nice leading question for the resident, that really helps everyone kind of understand the situation, what's going on, and it opens the door to a whole new discussion. So I really think that first attending that comments on that case has a really important job for the resident.
Yeah. Yeah. Healthy culture is important. And an unhealthy one gets quiet. Well, I guess it could be either probably two ends of the spectrum, really loud as people harassing each other and yelling and, or really quiet. And you don't want that either. You want a good discussion. And you'd mentioned it, Cody, you got to show up. You got to be there in person. And staff need to be there in person to discuss their complications. Sometimes there's good reasons, and we understand that. Oftentimes, I think it's really nice to share that reason. If, God forbid, you can't be there, to share why, so that I've gone as far as, hey, literally out of the country or whatever, and they wanted to present that case at a certain time, and tell them, matter, please tell everyone why I'm not there, because I would like to be there to discuss, these patients. Super important.
Yeah, I think one important kind of closing point is that M&M is one of the best opportunities to learn and teach how experts think. Like I said, it's become my favorite conference, and probably the conference I learned the most. Not just what the experts would do in that situation, but why. I find a lot of these key decision points that are discussed in M&M are when you're reading in the textbook, it's when it says to consider doing something. If you're in the situation, consider leaving a drain, or considering a lobotomy, or consider a temporary abdominal closure.
The hell does that mean? Yeah.
Yeah. So this is that time to okay, what does that mean? Going back to what we were talking about before, what is your threshold for doing that? And learning from the people who have decades of experience on when they consider to do those things, and not only when they consider to do it, but when they decide to do it. So, for me, it's it's not just the correct answer, but it's the reasoning that got you to that answer. And this is the time to learn that.
All right, guys, I think this has been great. But we've been talking for long enough for 3 or 4 M&M cases to have been presented. So let's finish up today by providing the listeners with just a few kind of quick rapid fire pearls that they can carry into their next M&M presentation. So I'll throw one out there to start, which is clarity over density. If the audience can't follow the story, they cannot learn from it.
Yep. A neutral tone invites better discussion.
Chronology drives comprehension. So build the timeline, and the decision points will reveal themselves.
That being said, highlight your decision points and explain why you chose an option over another.
And with concrete improvement ideas.
Remember that M&M is sacred, so treat it as such. It's a defining feature of surgical professionalism, and it's one of the places where we show what we stand for as a field. And at its best, it reminds us of why surgery holds itself as a higher standard, not because we're perfect, but because we're committed to getting better together.
Yes, sir.
All right, everyone. Thanks for listening to Behind the Knife. If you found this helpful, share it with a co-resident who's about to present an M&M, and send us your own best M&M presentation pearls. And as always, remember to dominate the day.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple, iOS, and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.